and welcome to today's webinar. We really appreciate everybody joining us today. I'm going to go ahead and get us started. To begin with, I want to welcome you. Today is about navigating the new HPH Cybersecurity performance goals. And we have the privilege of having two extraordinary guests with us, Ed Gaudet, CEO and founder of Censinet, and John Riggi, National Advisor for Cybersecurity and Risk for the American Hospital Association. Just a couple things to share before we kick things off. All of today's slides will be shared with you post-meeting, so be assured that those will get to you via email, as well as question and answers. We want to encourage everybody to ask questions on today's program, as it's a great opportunity to engage with John and Ed on some of these goals. And finally, we'll be addressing Q&A toward the end on the last 15 minutes. So make sure you use that Q&A function at the bottom of your Zoom webinar screen to take advantage of that. So with that, I want to go ahead and hand over the stage to Ed and John to kick us off. Thank you.
All right. Thanks, Saul. And John, I think it's time for a photo update. What do you think? For me, anyway.
For me or you?
For me. I think I've grown into my face over the years, so we'll take care of that. So we got a lot to cover today. I'm really excited. A lot has happened over the last month or so. So obviously with the relaunch of the CPGs at the end of the year, and then some additional updates there. But just on the legislative and the threat landscape side of the house, man, what is going on with Change Health, John?
Yeah, my goodness. Ed, thanks for inviting me. Always great to be here with you to chat with you. Yes, it's been quite a busy year. We started off with proposed standards, minimum mandatory cybersecurity standards for our healthcare sector. We consumed with that last part of 2023 and then 24, and then boom, Change Healthcare. It's interesting. We were just having a discussion prior that I was at the Rural Healthcare Conference about a week before, and we're talking about how third-party risk, business associate and third-party risk, is one of the major sources of risk that the entire healthcare sector is exposed to. A week later, we find ourselves in the midst of the Change United Healthcare ransomware attack. I think we can say that now with confidence. So on February 21st, we started to get reports directly from the field, from large health systems and small ones, that there's something going on with their revenue cycle services through Change Healthcare, Optum/United. It wasn't even clear to us at the time how these three companies were all related due to their merger and which particular systems were down. And subsequently, we did understand that a significant number of Change Healthcare systems related to pre-authorization for clinical care, pharmacy prescriptions, and of course, revenue cycles, submission of insurance claims and reimbursements were all simultaneously down. And ultimately, Change did confirm that day they were a victim, and I want to stress that, they were a victim of a cyber attack, and that they were dealing with it, and no timeline was established for restoration. Basically, at that point, I started to make some calls to senior leadership at FBI, HHS, CISA, and the White House directly to explain to them we're experiencing this significant sector-wide attack, and here's the implication, which they were not aware of at that point. Subsequently, Change did, in fact, confirm they were a victim of this attack from, as it turned out to be, a foreign-based criminal organization. Subsequently, we learned it was the group claiming responsibility was Black Cat, Alpha V, so Black Cat known as Alpha V as well, Russian-based, Russian-speaking ransomware group, very typical, operating from Russian territory, because the Russian government provides them safe harbor to operate and launch attacks. Although there was no specific information the Russian government was directly involved, the fact that they don't cooperate with U.S. law enforcement and provide safe harbor for them to operate does in fact make them, in some sense at least, passively complicit. So as time went on, we saw a very significant disruption in that first week. Fortunately, Change was able to get pharmacy prescription services and pre-authorization services back up. Still, to this day, major lingering effects on revenue cycle. They were a Change United Health Group was able to push indicators of compromise for fairly early on that Sunday. That would have been about February 25th. And then subsequently, the FBI and CISA pushed out a joint alert on February 27 containing updated indicators of compromise for the Black Cat ransomware group. And then their TTPs. So the impact is still lingering primarily on revenue cycle. Large systems, small systems. Change United Health Group and Optum merger, whether by design or default, created a sector financial utility. And many were surprised that even organizations they did not believe were connected to Change, like payment clearinghouses, were impacted. So every hospital in the country impacted directly or indirectly through this attack, and really exposed how vulnerable we are when we rely on a single mission critical third-party provider for these type of services. They have restored where we're at right now. They are restoring systems. There is still some disruptions to revenue cycle. And again, I think it's really a lesson for all of us to think about our business continuity plans in relation to mission critical third-party providers. Let me stop there, Ed, and get back to you.
Yeah, no, it really illustrates what we've been saying. Cyber safety is patient safety. Look at 74% of the hospitals reported direct patient impact. I mean, we can talk about the revenue impact, we can talk about the cash flow impact, but 74% direct patient impact, John.
That's right. Yeah, whether it was through disruption of pre-authorizations or pharmacy. And by the way, Change Healthcare serviced all the military pharmacies through TRICARE globally. So, of course, the big question we have still, which has not been confirmed, a couple of questions really. What was the point of intrusion? We still don't know that. I have that confirmed. And was their data exfiltrated? I think even based on public statements that Change has made, they indicated data has been exfiltrated, but they're trying to determine the sensitivity of it. Was it PHI? Was it personally identifiable information? And then, I mentioned, sorry, really what I'm concerned about with my government background is the fact that the identity of every active duty service member may have been compromised, if that's the case. So this is not just a healthcare issue. It's a national security issue as well.
That's right. And this is not a one and done. The hits keep coming. We've been seeing this buildup over the last few years, topping off at 136 million records in 2023. And now these systemic risks are just becoming greater and greater. SolarWinds was really just
that's right.
Was really just a small test, if you will, compared to this Change Healthcare and event. What comment on this, John? How do we stop this?
Well, let me just a general comment here on the evolving tactics of our adversaries. So foreign-based criminal organizations, sometimes working in collusion with or at the direction of hostile nation states like Russia, China, Iran, or North Korea. SolarWinds, for example, attributed to Russian-aligned hacking group. SolarWinds really was an instance of where the adversaries showed their strategy and tactics. In fact, the HA and the Health ISAC published a bulletin not long after that, advising folks to take a look at the strategy used by the adversary here. They identified a technology that was ubiquitous throughout all organizations, government and Fortune 500. And when this technology had certain characteristics, that it controlled network data, had broad access, had remote access. And the bad guys, in that particular instance, the Russians, figured out if we can compromise this SolarWinds, it'll give us, again, that broad access to data and to control networks. So at the time, we had made a recommendation, the Health ISAC and us, to look for other similar technology within your systems, third-party technology in your systems that have this broad authority, and then understand how that, if it was compromised, how it might affect your systems and your data, access to data, and how it should behave. The only clue on SolarWinds was there was some anomalous behavior, contact with a IP, but unless organizations understood that contact with that IP was anomalous, they never would have detected this. So the bad guys, in summary, have mapped our sector. They understand key pieces of technology that we use and are looking to compromise that technology. And they've also mapped our sector in terms of mission critical third parties, strategic nodes that have broad access to multiple hospitals or the entire sector and have mass aggregation of data. So they're simply attacking those nodes versus trying to attack 1,000 hospitals separately. They go after the common third party that has the data or access to 1,000 hospitals, in short. And the ransomware attacks, again, have been proving successful because if organizations are not prepared, they find themselves having to pay the ransom in healthcare, primarily because to preserve patient safety, and they end up paying. Of course, we don't want any organization to pay. We want to be prepared. Be prepared, don't pay.
No. And third parties are becoming more and more of the target these days. It used to be all of our assets were within the four walls of the hospitals. No longer,
Right.
That's no longer the case. Talk about what you've been seeing with third parties and business associates specifically.
Let me explain maybe what this slide is, which really demonstrates this that point. There's been a lot of talk, government, the media, whenever there's a big healthcare data breach, automatically it's assumed, boy, those hospitals have to do a better job at protecting patient data. But when you look at the actual data based on, this is a copy of data provided by HHS, Office of Civil Rights. We downloaded it right from their website. And what I did in this particular slide here is that we sorted for 2023 all the largest healthcare data breaches, those over 1 million. And these, we found, when you look at it, those in yellow, the breaches actually stem from business associates. Even HCA Healthcare, the largest breach of 2023, showed that it's related to a business associate compromise. And then those others in pink there, those are non-hospital healthcare providers like insurance plans, lab, pharmacy, health plans. And the one in blue, again, these are all victims. We're not casting any doubt or disparaging their cybersecurity programs. That you only have one hospital in the top 20 breaches. And just for reference, these top 20 breaches, it's only 4% of the total breaches reported in 2023, account for 75% of the stolen records in 2023.
The Pareto's law.
Yeah, exactly. And then I have to point out the entity which is calling for intense regulation against us, the Center for Medicaid and Medicare.
Look at, they're on that list, John.
They're on the list too, in the top 20. Nobody's
Right.
immune.
Nobody's immune. That's right. And speaking of nobody's immune, I think we got to do a better job at the top of making this and making cyber risk a board issue.
Right.
I've written an article about 2 years ago with Forbes that stated that just like we have audit committees and just like we have finance committees, we need a cyber committee at the board level where we're taking more responsibility of not just the cyber program, but the resources.
Yeah, agreed, Ed. And ultimately, I always say it is a leadership imperative and a leadership priority at the board level and, of course, at the C-suite for the leadership of the organizations to understand, first and foremost, cyber risk is not just an IT issue. It is, in fact, an enterprise-wide issue that affects every function in the organization. And ultimately, primarily, it is a risk to patient safety, most importantly, such as when you have a ransomware attack, which results in ambulance diversions. But it is also strategic risk. We have to understand that when geopolitics play a role here. So tensions between Russia over the invasion of Ukraine, tensions with Iran over Middle East, tensions with China over their aggressive actions in Taiwan. All of that creates increased cyber risk because these countries use cyber means as a tool of foreign policy and national security, targeting the U.S. and private sector, or they simply don't cooperate with U.S. law enforcement in terms of targeting criminal organizations that are operating from their territory. So understanding that nature, and then strategic risk in the sense of, hey, we're going to have a merger and acquisition. When Change, United, and Optum sought merger, the AHA publicly opposed that because we felt they were too big. And we had DOJ actually sued to prevent the merger, and they were not successful. But again, I think this proves our point that when you have a concentration of mission critical services, you also have a concentration of risk, which could expose risk to the entire healthcare sector. So the leadership has to understand that nature, enterprise strategic risk, who's the mission critical third parties, as you say here, and what do we do if we lose those services? And without getting very technical, without, these asking large strategic questions, as I have here, if you lose the internet, if we lose the network connection, if one of our mission critical third-party providers go down, three simple questions I always say: what will work, what won't work, and what's the plan? And really creating accountability in every department to prepare these contingency plans for all mission critical technology, internal and external.
Yeah, and it supports that trope. It's not a matter of if, it's a matter of when.
Right.
So be prepared to respond and recover from the event accordingly. Let's move on. I know this slide talks about a lot of the resources available that the AHA makes available, as well as other organizations, to providers to help them navigate the Change Health issue, and also some of the other issues that have happened over the last year or so. You want to comment on any of these resources here?
Yeah, ultimately, again, we would encourage folks to look at these resources, not only just on the cyber side, but the AHA was very vocal and very forward-leaning, if not aggressive, to ensure that, for instance, the government advanced Medicaid and Medicare payments to those entities that were feeling an impact of loss of revenue as a result of the Change Healthcare attack. Issues also discussed about what are our obligations under HHS Office of Civil Rights Reporting if data has been breached. Again, want to clarify, there's no confirmation that any data has been breached. So the mandatory timeline for reporting does not start until there's confirmation of breach. But we've asked for clarification from OCR on who would have primary responsibility to report breach of health information in this instance in Change Healthcare, because there literally could be tens of millions of records compromised. And our position has been that only Change United should have the responsibility to report, not the thousands of hospitals potentially to report to that breach to patients. So lots of resources there, anticipating the issues, of course, a lot of cyber threat intelligence, and then the preparedness piece. Folks, this is really a wake-up call for all of us. We've got to think about business continuity, clinical continuity in the face of losing these mission-critical services. So again, I would encourage everybody to look at these.
Yeah, and we'll send this out to folks after the webinar as well as a reference deck. So let's get into the topic of the day. Let me just get here and do this. There we go. The cybersecurity performance goals that were announced at the end of the year and have been through a number of updates. So let's start with, what are they, John? What are these goals, and why are they needed?
Yeah. So obviously, healthcare sector has been the primary target for foreign-based hackers of all critical infrastructure sectors. The government's data, anecdotal data, we know healthcare, hospitals in particular, are targeted more often than any other critical infrastructure sector, because they know that because of the way we're structured, our networks are very expansive. We were designed to share information to make it broadly accessible across various providers and with payers and medical device manufacturers. And we're relatively new when it comes to the digitization of records. It was only in 2009, 2010 that healthcare received a mandate and incentives to digitize healthcare records and make meaningful use of technology. All well intended, but that expanded our digital attack surface incredibly. So as a result of the ongoing attacks, a lot of the sector, including UED and Censinet, joined with us together and with the government to figure out how are we getting beat from the adversary perspective? How are they beating us? You know, you can look at all types of frameworks, but just having a framework might not actually prevent the methodology of the attacks. So we looked at that, and based on how the attacks are occurring, we came up with 10 essential cybersecurity practices and 10 enhanced practices. And these were developed as voluntary practices, best practices in collaboration, again, with the government and across the sector, lots of experts. And again, appreciate Censinet sending out the survey to help inform this project. And, you know, there can be some discussion or debate of what should be essential, what should be enhanced, what should come first. Should asset inventory really be enhanced, or should that be essential? But bottom line is, in the AHA, we all agree on these practices. There is no debate, no discussion that we need to, as a sector, improve our cybersecurity posture where we reasonably and financially can. And we agree with all of these practices that were outlined by HHS.
Yeah, and just to point out, there were a number of organizations involved in the making of the landscape analysis report, including Class Research, who helped us on the initial survey data, HISAC with their survey instrument.
In the
as well.
healthcare sector coordinating council,
That's
great partners. We worked very closely. When we received the request initially, we brought in the healthcare sector coordinating council to kind of lead the way on this on behalf of the sector.
Exactly. And so just quickly, what's the difference between the essential and the enhanced?
Well, ultimately, you know, based on the collective expertise, it was decided and the methodology of the attacks that the essential CPGs are those vulnerabilities, those security practices, which we believe would mitigate the majority of cyber attacks based on the bad guys' tactics, techniques, and procedures. So we know that they are getting in. One of the top ways they're getting in is not through a zero-day exploit. It's through exploitation of known published vulnerabilities. They're simply hacking before we can patch, quite frankly. And email, phishing emails, social engineering, I would add on top of that, continues to be one of the top tactics to compromise credentials, compromise multi-factor authentication, perhaps, and get into our networks. And we know, based on case study analysis, that multi-factor authentication, that technique alone could block a substantial number of attacks, because you have a foreign adversary with compromised credentials trying to log in externally. And unfortunately, we have seen, even to this day, not all organizations are using multi-factor for remote access. Let me stop there, Ed.
Yeah, no, it's great. So the essentials represent that baseline of controls that need to be put in place to deal with the threats,
right?
The most, the highest or most critical threats, if you will.
It's kind of a roadmap as well,
Yeah.
Ed, for like an organization that doesn't have a mature program. And where should we start? Look, there's a lot of folks that are on this call that we've seen that have mature programs that these are pretty much standard.
Right.
But with folks where we get calls, John, where do we start? And we point to these 10 essential CPGs.
Yeah, the essentials represent that standard of care that you should be doing at a minimum. And then as you develop your maturity of your program, move to the enhanced set of CPGs over time. And so, speaking of timeline, let's get right into it. There's been a lot of updates over the last few weeks, if you will, in terms of funding on the incentive side, as well as some insight into the penalties that may be coming over the course of the next 3-5 years. So why don't we talk about the budget, John? So what did you like about this when you saw this come out? I'm sure you were pretty excited about.
Well, let me just start off by, before I get into what I don't like about it, what the AHA on behalf of the hospitals, the membership, does not like about it. Let me just say, first of all, we appreciate the partnership with HHS, CISA, the White House. And even though we may disagree on certain paths to better cybersecurity for the healthcare sector, we all agree. We want to protect the healthcare sector. We want to protect patients first and foremost. So we all agree on the need to enhance cybersecurity. Where our opinions diverge, it will be on some of the aspects of how to implement this. And we appreciate HHS and the White House listening to us that we do need resources. Those under-resourced hospitals, small critical access hospitals, are going to need some help. So we appreciate that there was at least an attempt to provide some funding, and I would say it's an attempt because the 1.3 billion which would be provided over the 5-year term here, quite frankly, is not a lot of money. I know it sounds like a lot of money to folks, but when you spread it out over 5,000 hospitals, and even if we just did 2,000, the rural hospitals, it's really not a lot of money when you talk about implementing third-party risk management program, encryption, all types of these other controls. So that's where we diverge. One, insufficient resources. Two, the issue of the penalty phase is very, very severe, and it only targets hospitals. So the proposed penalties talk about limiting incentives, what they call a market basket increase of, bottom line, not a policy expert on that, but it accounts for millions and millions of dollars of penalties for individual hospitals, plus potentially 1% reduction of all Medicaid and Medicare reimbursement. Huge, huge penalties. The program or the proposed rules also talk about enhancing existing HIPAA penalties for hospitals. And our point is, as we've demonstrated, we can show by the Change United Healthcare that the majority of the risks that we are facing as a healthcare sector and our patients are facing originate from insecure third-party technology and insecure third parties, right? We don't write our own operating system code. We don't build our own medical devices that allow this ransomware to attack us. And how do you secure just hospitals only if we are in a totally insecure healthcare environment?
Yeah, no, it's a great point. And the analog is meaningful use was the first step, but without the interoperability legislation and rulemaking, you've only solved half of the problem on that side.
Exactly.
And so you've got to solve the third party issues as well as making sure that the health systems are doing the right thing and
Right.
providing that right standard of care. Because as the early data showed, more and more of these attacks are coming from the third party side.
Right. And then again, you secure the hospitals. It's like being a forward operating base behind in hostile territory.
Right.
We'd be this outpost, and then everything around us is hostile, and not understanding, hey, that's where the threat is coming from.
Mm-hmm.
And then of course, I always talk about really, my opinion, there's really 5 components to enhancing cybersecurity for the healthcare sector. The first is, let's start with better secured technology. I mean, we totally agree with the White House's initiative on secure by design, secure by default. That's what the vulnerabilities are exploiting. 2, let's make sure our third-party providers are better secured. Whatever's good for us should be good for them. 3, let's make healthcare records less valuable so they won't be stolen. So what does that mean? And then I always ask the question, why are the bad guys stealing healthcare records? Because they're valuable. Why are they valuable? Because it's easy to commit healthcare fraud with those records. So maybe health insurers should do a better job at detecting and preventing healthcare fraud. And that at least would stop the data theft portion. 4, yes, we need to do a better job as hospitals and health systems on cybersecurity. We won't shirk our responsibility, but wherever we can, reasonably and financially. And then the 5th point I always make is, just as much as we do on defense, the government's got to do better on offense as well. We got to go after the bad guys more, impose risk and consequences on them.
Yeah, we certainly don't want to see government agencies on that list that we saw earlier. That's for sure.
Right.
So let's move into the timeline. Again, a lot just came out recently on this. So take us through this right-hand side of the slide.
So again, we appreciate there is time. So not only there's an effort to produce resources, there's time for implementation. We were concerned initially that there was policy being driven from the White House that would perhaps accelerate the timeline for 1 year, which would have been really exceedingly difficult for us to implement. So HHS has taken a more practical approach. Fiscal 27-28 provide $800 million for hospitals in need, high need hospitals. We're not quite sure what that means. And then to implement the essential practices. Then fiscal 29 and 30, penalty phase, right? So here comes the penalties. We're giving you some time. And then where those penalties for those that don't meet those essentials would be potentially penalized. And then 500 million in those fiscal years to help hospitals meet the enhanced goals. Bottom line, by fiscal 30, all would be subject to penalties, very harsh financial penalties, if they do not meet essential and enhanced CPGs. So again, it's the resource issue, the heavy enforcement penalty phase, the enforcement mechanism, and the heavy penalties that which we strongly oppose.
Yeah. And we're still in the rulemaking phase too. And how long do you think that's going to take?
Well, it'll depend. We're waiting for the rules to be announced. We hope for significant public comment period. We will certainly have lots of commentary, and where we hope to shape and influence how these rules are actually implemented. And of course, we'll rely on the sector as well to help communicate with us, inform our positions, and help demonstrate real-world examples of why this would be a challenge for hospitals to implement, and perhaps what are the financial implications and the resources which might be needed. So we'll be calling on you in the field to help us formulate our official responses to the proposed rules.
And so you're looking for input from the leaders, obviously from these hospitals and health systems, third parties as well? Are you looking for
third parties? Folks can say that, because one of our positions will be, and we've said it publicly, is that cybersecurity performance goals applied to hospitals alone will not help secure the sector. And perhaps we need CPGs to be mandatory for third parties as well. So that, for instance, if you're dealing with the defense contracts, it's understood you have to meet a certain level of cybersecurity standard before you even apply for the contract. And if CPGs were mandatory for third parties that wanted to do business with healthcare providers, just think of all the time it would save individual hospitals negotiating every individual business associate agreement with thousands of providers. Quite frankly, it would make it easier for the third parties as well. So we know here's the standard we have to meet, and we're showing evidence of that.
Yeah, as a third party that's part of the ecosystem, we highly recommend third parties do follow the CPGs, even if they actually are not in the legislation. We think it's the right level of hygiene and the right level of standard of care. And it's going to make it a lot easier for you to work with providers that are now held to, or going to be held to, higher standards.
I agree. And quite frankly, our guidance to the field would be only deal with third parties that meet the CPGs.
Amen.
So there's, cybersecurity also has a positive business component to it as well. Cyber will sell, and market forces may, whether it's regulated or not, market forces may demand and drive third parties to comply with the CPGs.
That's right. And just don't do a one and done. Make it part of how you go to market, how you actually not only produce secure by design, secure by default, but also when you deliver those technologies, you're actually putting in the right level of hygiene and the right level of controls that you can prove to providers that are also held to a high standard, that you're doing the right thing for the industry and for the sector. I love that, John. So we're going to wrap up this before we get into the next topic. Key takeaways. I have a couple. We've captured a couple here. Any you want to call out?
No, again, I think you've captured these, but again, really to think about that cyber risk in a enterprise risk issue, strategic issue, factors that are influencing cyber risk, which may be beyond your control. Geopolitics. Third party, though, that's an area that we can probably do a better job at controlling. And then I talk about the collaboration piece. And again, thanks you again, Ed, for you and Censinet collaborating with us in the government, is really to share, collaborate, exchange threat intel across the sector and with other sectors. So if you have relationships in finance, and manufacturing, defense, I find it's very helpful for organizations to exchange information even outside the sector, and then to work closely with the government. The FBI, DHS, CISA, and HHS are very open to collaboration with us, and they do not share information with the regulator, with OCR. In fact, your communications with the government are protected under various statutes on cyber threat sharing. So I would encourage that. And again, it really just helps make us all stronger when we have this cross-sector and government collaboration.
Yeah, I love that. Thank you. And I think, for those CEOs and COOs and CFOs, lean into this now, start to really understand what CPGs are and how your organization can obviously begin to budget for these, begin to prepare for these, and also lean into providing your own recommendations, suggestions, input into that process for rulemaking, John, right?
That's right.
So they can work directly with you and your organization or they can send their own comments directly into the HHS. Is that correct?
That's right. And Ed, I do want to point out the geopolitical aspect right now. As you see, we watch the news every day. Tensions are increasing very significantly and across the globe, especially with China. And I do want to point out there have been recent alerts issued by the government, which has identified destructive malware on our telecommunications grid and internet service provider grid, impacting communications between the U.S. and Southeast Asia. Heads of the FBI and other agencies recently testified that the government of China is pre-positioned to disrupt our critical infrastructure should hostilities break out in the South China Sea, with potential invasion of Taiwan. We really have to think about that. If the government is saying that, how well postured are we? Should we use some of our utilities, third parties that succumb to these attacks? So again, I just can't stress this enough. We really want to be preparing our business and clinical continuity plans this year and next year.
Yeah, no, that's a great point and a great reminder to folks. So we got a lot of questions coming in, so we're going to get to those in a second. So for folks, please hold on because some of these questions are very interesting. And I think you'll want to hear the answer to those. John, we recently were selected and awarded by you for another couple of years as a preferred cybersecurity provider. Can you talk about that and what it means to your members?
Yeah, we appreciate that, Ed. Again, we appreciate your support for our nonprofit advocacy. And bottom line, this program was started based on multiple requests I received saying, John, just help us distinguish and sort out the signal from the noise here in the cybersecurity field. We know that the field is saturated with cybersecurity vendors, and we did develop this program to help vet and recommend preferred providers. And quite frankly, what I was looking for are organizations like yours, Ed, that not only just want to sell to us, but want to serve with us. And that's what we, after my decades in public service, that's what we look for. Folks that really want to help hospitals and health systems on their noble mission to protect patients and serve their communities. So you all exemplify that, and we really appreciate it. And we know that our members appreciate it as well.
John, thanks for that. And Censinet does have support today right out of the gate with CPGs. So if you're interested in learning more about that and how you can assess yourself, your organization as it relates to your coverage of the essential and enhanced CPGs, please reach out to Censinet for more information there. We also have that across peer benchmarks too. So we talked about those benchmarks and those earlier that we provided to the landscape analysis project that led us to CPGs. So if folks are interested in learning more, please reach out to Censinet.com for that. Okay. And again, you get not only an ability to manage your coverage of those goals, the essential and enhance, but you get to see how that relates to your coverage versus your peers' coverage across the different areas of focus, as well as the mapping back to frameworks such as NIST CSF, and best practices such as hiccup, which is part of the 405D. Okay. All right, great. I was excited to get the questions, John, and I wanted to leave some time here on the clock. So I'm sure my sales team will beat me up afterwards for rushing through that.
Well,
All right.
again, it exemplifies you're out there, your primary focus is helping folks. And that's, again, we appreciate that, Ed.
All right. So Saul, you're back. All right. So we got a lot of questions. Let's go.
We do. We got a
Yeah.
lot of really great questions. Appreciate everybody's participation. So there's a couple here, Ed, and also John. So this
Okay.
one says there appears to be a checkmate. Do we need to just be focusing on business continuity since our own security defenses are so easily breached? Great question.
Well, from my point of view, we still need to do both, right? We cannot acquiesce on defense. We need to put as much resources as we can on the defensive side, because that still will prevent a majority of your attacks. If we de-emphasize defense, we would be under attack, successful attack constantly. What we're suggesting is we need to be prepared in those instances when the attack is successful. So we really need to do both. And to our point to the government, that we need a lot of resources to defend against attacks and to be prepared to respond and recover from them.
Thank you for that, John. Here's another one. Will hospitals need to notify patients about the Change Healthcare breach?
Good question. And that's the same question we have asked Office of Civil Rights. Again, I want to stress I'm not a lawyer, and you should consult your own attorneys internally on the regulatory requirements. However, the AHA has asked for that answer, has asked that question to OCR. We have asked formally OCR that hospitals be relieved of their reporting obligation should Change Healthcare, should it be determined there was a significant breach of PHI. So there is precedent for that. And during the Anthem attack in 2015, which was the largest healthcare record on breach, almost 80 million patients, only Anthem had to report that breach, not the thousands of hospitals whose data was actually affected by the Anthem breach. So we hope to hear from that. And who knows, maybe it won't be an issue. I'm hoping it won't even be an issue, and that whatever was stolen was not readable or retrievable by the bad guys.
Thank you, John. And of course, we appreciate the advocacy there on behalf of hospitals, and there's a precedent. Okay, we have another one here. Can you please share thoughts? What does a perfect state look like? Breaches will occur just like auto accidents continue to occur in spite of many major safety breakthroughs in modern vehicles. The question is, what needs to be done to shift from a CYA approach to accountable, no-risk, third-party product platform selections?
And I'll take a quick shot and then turn it over to you, your thoughts there. First of all, there is no perfect world, and there is no zero risk. As you said, we have to plan for the risk. We have to plan for the attack being successful. I think a perfect world would be where we are able to mitigate the risk to the lowest possible acceptable level of risk, but again, still have to be prepared. Going forward, as we expand our use of technology in our interconnectivity with third parties and fourth parties, our attack surface will continue to expand. And again, I think doing the best we can on defense, maybe the use of AI to prevent and detect attacks, but we have to be prepared to respond. And ultimately, if there was a level playing field in terms of regulation, all third parties would take as serious their obligation on cybersecurity as covered entities do.
Yeah, I love this question. There's a lot to unpack here, especially with the analogy of motor safety and vehicle safety. So, first of all, auto accidents do occur, and we do have major safety breakthroughs. But I would want to make sure I have the right insurance coverage there. If there was an accident that did happen, I'd want to make sure that my bag did work correctly, my to protect me in the event of an accident. I want to make sure that, you know, the vehicle's been tested and the crumple zones work accordingly, and I'm not putting myself in undue extra danger, you know, if I get into a minor accident versus a major accident. Um, you know, we'll continue to make those breakthroughs on the auto side, just like we need to on the cyber side, especially in healthcare. And I think that, you know, the more things like, for example, maybe what we need to do is start um, leveraging insurance as a way for folks to do the right thing. So tying insurance directly to what folks are doing in terms of hygiene, what they're doing in terms of the CPGs, and then their success record over time, just like you do with auto insurance, right? If I'm in an accident, you know, every other week, my insurance is going to go through the roof. In fact, I'm going to become uninsurable at some point, right? And I think, you know, we do have have to have that level of standard and duty of care that enables us to manage within those constraints and manage within those risks and threats that occur every day. So I think from an accountability thing, the first thing is just making sure we all understand what the baselines are. There's enough of an understanding of, you know, what happens if we don't support the baseline. So there's an incentive, and I do believe that there should be, you know, some type of, you know, carrot and stick combination like we have with meaningful use. We could talk about, you know, what we learned through the meaningful use program. But from a cybersecurity perspective, we have to stop putting patients' safety at risk. We have to do a better job of making sure that we have the right, not only controls in place, but we're continually monitoring and making sure that we are, you know, obviously putting the right investments and have the right controls at a corporate level, at an organizational level. That's why it's so important that the board become accountable at some level for cyber risk and cyber safety. And so we have to do a better job, not only at the cybersecurity tactical level, program level, maturity level, but we have to raise that accountability at the board level. And I think once we do that, we'll see a much better aligned organization to support the threats, to support the investments that need to be made in order to respond and recover accordingly. Because we know, given the complexity of technology, the rapid change, and how reliant we've become on third parties, it's not a matter of if, it's a matter of when. So we need to be able to recover accordingly. So there's a lot there, and I could spend probably a couple hours just talking about that question, and how it relates to what we need to do not only today but in the future. John?
No, thank you for that, Ed. Thanks for unpacking it, and thank you, John. Great question. Here's the next one. Is there any talk of enforcing CPGs? Should DNV JCO include these items in their audits?
So again, the enforcement mechanism has not been elaborated, enumerated, right? So they're going to go through the rulemaking process. There is discussion of various regulatory bodies, or I should say review bodies, such as the Joint Commission and others, as mentioned, being the mechanism by which organizations are audited. So again, we want to see how the rules play out, and depending on what is proposed, we may or may not support that. Again, it's a lot for us to ever even get to that point. We want to see more resources. We want to see the penalties mitigated before we get to our position on who should be the auditing body, or how would organizations certify. So stay tuned on that one, bottom line.
I mean, it would make sense if patient safety is a civil right, then why wouldn't we continue with the Civil Rights Office as the enforcement mechanism? John, any thoughts?
Yeah, again, we don't disagree with the need to improve the security. And listen, Ed, you and I were talking about cyber risk as patient safety risk issues years ago. And so we absolutely agree on the need to do better and to implement controls. Again, it's just the enforcement mechanism.
Yeah.
So the devil, as they say, is in the details. Stay tuned from the AHA side anyways on our position on that.
Okay, I couldn't get you to take the bait there. All right, John. I tried.
Thank
All
you,
right,
guys.
Saul.
Yeah, here we go. Lots of questions. Thank you all, and please keep them coming. We have 9 more minutes to address these. Does Censinet have a CPG checklist yet, or are most all covered already on the tech checklist?
Yeah, thanks for that question. I kind of went through that quickly. Censinet has added a CPG capability in its benchmarking and peer benchmarking capabilities. So we've mapped it to both HICCUP and NIST CSF. So if you're in the platform today and you're working with NIST CSF and HICCUP, we have an easy way for you to populate your benchmarks for CPG and see where you stand today, and use that as a baseline for maturity and progress over time.
Thank you, Ed. The benefit of having a specially named CPG checklist is education advertising for the CPG is why it exists, etc. Sorry, I guess this was just a comment.
Yes, that looks
Okay,
like it. Yep.
got it. Thank you for the comment. All right. Is the US the only country suffering this level of healthcare attacks, other than maybe Ukraine?
It is not. Unfortunately, this is a global risk issue. I spoke in Lisbon in October at the International Hospital Federation. I'll be speaking in Rome, if you happen to be in Rome, at the end of May at the HIMSS Europe conference. Unfortunately, this is a global problem. And of course, you can imagine in countries that utilize technology more industrialized country, this is a significant issue, including in the Mideast. But Western Europe, North American countries seem to be targeted the most based on the data. And again, are based on use of technology. It is, of course, we are not receiving reports from Russia, China, Iran, or North Korea. And I will just say that based on information, and the forensic review of Russian-speaking ransomware gangs, we know that those gangs do not target Russia or its associated states, because again, they're their host nation. So primarily the West and the United States have been targeted by these attacks.
And thank you, John. In organizations without a CIO, how can executive teams effectively lead cybersecurity preparedness?
Yeah, do you want to start? I'm happy to start again, but
yeah, there's a couple of different ways. I mean, the chief information officer is obviously responsible for the technology and the implementation of the technology in support of the business. If there's no CIO, I'm sure there's somebody responsible for the technology at some level. You didn't ask about a CISO or a chief information security officer not being there. So ideally, I would have that person lead this effort in terms of preparedness. But if you don't have a CIO or a CISO, or someone in charge of security or IT operations, you can always work with a third party, and there's plenty of programs for virtual CISOs where they can help you on a contracting basis to prepare for, supporting of the CPGs. You can work with third parties like Censinet. You could work with third parties as a managed service provider. So someone could actually be an extension of your overall team and help you develop those policies and procedures, and obviously what needs to happen and what needs to be implemented to support the CPGs. John?
Yeah, Ed, I would only add again that most hospitals, I think even the smallest hospitals, have an IT director.
Mm-hmm.
So that responsibility falls on them quite a bit. And of course, it's generally the IT directors, also facilities and cybersecurity on top of that. So a great point about using external third parties, virtual services. By the way, cybersecurity services, third-party cybersecurity services are also targeted. So you always want to check on your third-party cybersecurity providers, their level of security. But then, making IT or information technology a C-suite issue, or even a board issue, where there's a relevant subcommittee of jurisdiction for the board, that would help govern acquisition of new technology, implementation of technology, and then, of course, raise cybersecurity concerns at the outset of the onboarding or when it's being considered prior to purchase. So making it actually an executive responsibility overall if you have limited staff capability.
Some great insights there. Thank you, guys. If an organization implements the basic recommendations of SP 800-66 and SP 800-53, would that cover the essential CPGs, or are we going to see a major overhaul in the NIST special publications in the following years?
So, I'll just add, and my commentary is that the CPGs really are incorporated. Those practices really are parts of NIST and HICCUP, the healthcare industry cybersecurity practices, but it does not align to a specific framework. We wanted to make the CPGs framework agnostic. And our point was, what are the practices, regardless of what framework they come from, that we have shown would successfully stop the majority of cyber attacks? So simply saying that we are compliant with NIST 853-66 would not necessarily make you in compliance totally with all the CPGs. So you would have to align each CPG with each function of NIST, each framework. I think they're all covered in there one way or another, but just so you understand our approach. Our approach wasn't to align the practices to a framework. It was to align the practices to how the bad guys are beating us.
Yeah, and 66 is the cybersecurity resource guide for implementing HIPAA, and 53 really is a set of
Privacy,
security
yeah.
and privacy controls. Those things obviously are supplemental, should be looked at, should be used, should be followed, especially 53 from a control perspective. But there is a mapping that is in place for NIST CSF as well as HICCUP. So we would suggest you look at NIST CSF and HICCUP first, because many people have already done the work to support those frameworks and set of best practices. So start there, and then you can back into the 66 and 53 special publications.
Right. Again, totally agreed. Whatever, if it does the regulation, though, just ensure that those regulated practices are covered, regardless of which framework or standard you're using.
That's right. Yeah. Yeah. In the CPGs do point to the controls specifically. So, again, that mapping is all there for you. So you can start there, and then you can back into the different 66 and 53 pubs. All
Great.
right.
Great question, great answer. 2 minutes left. We got a comment and then one last question here. Great webinar, really appreciate it. Going to start asking my healthcare third parties to fill out their CPG to start out at a high level view of their controls. So that's awesome.
Good.
Great to hear. And last question here, can orgs still apply to be a part of the APCP program and provide help to health organizations needing cybersecurity guidance, or has application period closed?
We are taking applications. We do not have a defined period now. It is by invitation only. So this is an exclusive group. Folks can reach me if their third parties are interested in becoming part of this small exclusive team. They can email me at jriggi, JRIGGI, @aha.org. And if we feel that you would meet the preliminary, first, I'll just tell you, folks, before we even schedule a call, I need 3 references and 2 case studies before we even schedule a call. And then we'll start the application process.
Not only that, he does backdoor checks too. So
and push-ups too.
So it's a rigorous process. The due diligence process is rigorous, and we've
and
gone
Ed,
through it
even though
twice now.
you renewed, you still had to
That's
go.
right.
We worked
That's
together
right.
you still had to go through the same process
We did.
again.
You bet. Well, appreciate everyone's time today. Obviously, this is a topic near and dear to everyone's hearts, probably on this call today. Otherwise, you shouldn't be on the call. So we appreciate your time, and stay tuned, because we'll continue to update on this topic over the next couple of months.
Thank you all.
Everyone for joining.